many of you may know Pat. Pat's got significant strategic experiences in terms of workforce planning and as a workforce policy analyst in both the health and public care sector, and she's worked with a number of sort of national policy boards and trusts in terms of advising them. So Pat's going to talk a little bit around about the development of the integrated care system in England. Hello, Pat. We can see you. So.
Oh right, I can't see anything, I'm afraid.
I think maybe Ellie can pull up your slides if we're having problems
hang
with
on,
that.
let's see what we can do here. Have you got the slides on the screen?
Not yet from me.
Anything on the screen?
So I wonder if Ellie can do that then. Oh no, something started, Pat. Yes, so we've got we can see all of your slides. So maybe you want to click into the first one. Yeah.
Can you see that?
Yeah, that's fine. We're fine now. I can certainly see it. I hope everybody else can.
You can see the slides, and you can hear me?
I can hear you fine, thank you.
All right. We're out of time actually, so I'm going to rush this. Which we'll just have to unpack the detail on another occasion. But if I just focus on the problem in England, we've got the critical problem that we've got legislation bogged down in Parliament. So there is a reorganisation coming, you all know about that, for the ICSs, but the legislation has not yet cleared Parliament. So we don't have it's a bill, it's not an act. The act we have to wait for, because until we have that, we don't have the standing orders or the standing financial instructions. So I'm giving you my understanding of the situation, but it could change because of the new standing orders when the bill becomes an act. So it's complicated. In addition, the Secretary of State for the English service has just announced he wants a second reorganisation on top of this one. I don't know how they'll run together. So this one is about the accountability of CCGs to make the ICSs and incorporate HEE in the workforce planning function within NHS England and improvement, plus the digital bodies. So there's a five-way merger going on there. So that's going to be complicated. But Secretary of State has indicated that he might like the idea of academies that are currently running in the education system, where you have a group leadership model, and that runs slightly counter to the bill that's in Parliament at the moment. So we don't know how that's going to work. He's just floated that one. Plus we know the social care reform bill is due in the spring. And that's really important because it runs in with the local authority reforms and the whole structure of the agency to collect the money for the elderly with the new care system. And we don't know how that's going to work, whether that's an embed within the ICS or whether that is running an NHS and social care system under the local authority separately. We don't know yet. So I'm just putting those caveats up. And let's just whiz through this. So what's the problem to solve here? Strategic workforce planning. Well, it is that because of really good investments in health, social care, education, housing, etc., since the Second World War, that actually we live on and on and on. So we can expect much longer periods of life. And ONS, Office of National Statistics, has just worked through the projections to show that peak death, because people will die, but it's postponed to about 2044, which means between now, 2022 and 2044, broadly the next 20-25 years, different in different parts of the country in England, that actually all those people who are the baby boomers, who are older, are going to die. So therefore, the big imperative, and the Lancet just published a paper last week to show that we probably in the first instance need to increase community and primary care capacity by 42%. I think that's an underestimate, and I'm going to show you why. This is why strategic workforce planning is actually quite important. So what are the big killers? What's actually going to allow people like me to live, and then get to the crest, and then we die? The three things that we have to look out for are cancer. 1 in 2 of us will have a cancer diagnosis, and we'll go through not the first, not the second, but probably 3 times. Cardiac and stroke, so cardiovascular services, function of age, a direct correlation with the age profile. So we need a lot more cancer services, a lot more cardiovascular, and mental health. Remember, all those elderly people going through, 60% at least will have problems of failing memory and fragility issues, Parkinson's, Alzheimer's, etc. So we have to expand. I hope you can see very quickly there that the community and primary care capacity is a long-term issue. So patient numbers and capacity issues is the deal. We also have projected poverty and inequality issues, and we know because of the pandemic there are differential death rates. So actually there has to be some sort of equalisation, and that will be done through the financing and planning instruments, which may be or may not be in the bill that's currently before the House of Lords at the moment. But we have got underlying financial and debt management issues. So actually at the same time, you have to make the system efficient. And the way we're going to make the system efficient is technology. So 3 big investments of the state to help us. Now, you can do nothing about this. The state has already made these investments. The train has left the station. We have to now cope with the manpower issues that arise from these 3 investments. So the first is primary and community care. You need to currently Lancet is saying 42% increase in capacity. I think it's higher than that, but we've got to work the maths out. We've got to start doing those projections. To get in front of that, Treasury has permitted a $5 billion for the English Community Asset Technology Investment Programme. So that is the beginning of the development of new care centres. And we've got a working example of that for you in a moment, but there'll probably be about 200 care centres developed. So they're not hospitals, and they're not GP centres, and they're not health centres. They're a care centre. It's a different concept. Bit like a community hospital as was, with some of the Darcy sprinkling of polyclinic in it. 5 billion, that fund has just been topped up, so we're going to have more of those. Who works in them? Is that nurses, social workers, care assistants? Are the GPs going in? Let's have a look at the model for the workforce in community centres, community care centres. The current model of GPs, the practice partnership born and raised of the 1911 National Insurance Act, is probably not going to do for the 21st century, because 2/3 of GPs now are employees. So therefore, the government has allowed, and this is why we need to see what's in the legal instruments about the big reforms coming into general practice. So the migration up from the 10,000 list size, which is what you're used to with your sort of 2-man practice around the corner, through the primary care networks, through the now corporate conglomerations. A lot of American companies involved in buying them up, but GP practices buying them up. So we migrate from the 10,000 list size up to 1 million list size. Once you do that, you can change radically what goes on in primary community care, and you change the skill mix. So the issue is, of course, we will need more GPs, but how many? It's likely we're going to need a lot more primary care workers who are not doctors, but they work with doctors. Plus, and there may be paramedics. Do we need to expand paramedics? Social workers, care assistants. So the model of manpower for the expanded primary and community care programme actually is very important for us to start to bottom out. Also, because of the cardiovascular cancer services, we need a lot more rapid diagnostic and imaging services. So the state has invested on your behalf, more of that in a moment, but a massive expansion of what are called the high street services. And this will probably involve many of the community pharmacies who will, I mean, they're currently involved in the IMS and VAX programme and the normal community pharmacy, but are they also going to expand? Because remember, Boots is owned by an American conglomerate, Lloyd's is owned by McKesson's, etc. So this rapid diagnostic imaging expansion, what's the manpower model there? What's the technology, and how are the staff trained for that? So we've got coming very, very fast, rapid changes in skill mix and deployment models, and the issue of working with big business and private equity who are standing behind this. Remember BlackRock, KKR who bought Boots and sold it on to Walgreens in the States. These people have budgets of billion dollars, so they've got deep pockets. So this is very important for us to start to have a think about. This is my local centre. I'm here in Wimbledon in London. This is the Nelson Care Centre. It's 2 streets over from me. So when, as a patient at St George's, my local teaching hospital, for outpatients, imaging, X-ray, diagnostics, big pharmacy service, I can walk over to the Nelson Centre. I don't have to go to the big hospital, which is a very crowded, busy campus. Squillions of people there. So as an older person toddling over to this care centre, it's an old Victorian community hospital that was derelict. It's on the right hand side of this picture. It got gutted and rebuilt, and then part 2 is this fabulous therapist theme park is how I would describe it, and there's 2 GP practices in there besides big pharmacy, imaging and technology centre. And phase 3, which is on the right hand side, not in picture, is a retirement village. Because what's coming is the big expansion for the elderly is aided living centres. So here, this is 2 streets away from where I live. This is a redevelopment. This cost 10 million, by the way, which is part of that community asset technology programme investment, is a redeveloped community hospital with a therapist and technology centre plus an aided living centre to the right. And we're having 200 of those. And this one's now 8-9 years old, and it's a fabulous resource. But if you want to have a look at some others that are much more recent, in Scotland, southwest of Glasgow, Paisley, fabulous new development in Scotland, and in Derbyshire at Belper, where they've got, as you know, a community hospital from the Victorian era. In fact, Derbyshire has 6, and the redevelopment of them with fabulous sort of shishi block of flats, but they've got a big car park where one of these is being built. So it changes this whole issue of what does care in the community look like. Okay, so enough of that. On to the agenda rising, which is the workforce issues, age, skills, hours profile. We are hemorrhaging staff, but the critical thing to look for is not the head count, it's hours. All the people you talk to are dropping their hours. So instead of working 40 or 50, as soon as they can, they're coming down to 30, 25, 20, etc. Quality of life issues are important, particularly for medics. So therefore, we are losing hours in the system, and we have to understand what does that do to our workforce requirement in the short term? And then how do you design jobs that people want to do that actually they can live with, given quality of life is an important psychological anchor? Secretary of State has asked that we integrate physical and mental health care, very important in children's services and elderly. I put to one side the forensic service here, so we have to start to look at what does that mean, particularly skill mix across the care assistants, currently segregated quite heavily between therapists and nursing and between mental health care and healthcare. So actually, what does that sort of pooling of the care assistant agenda look like, and therefore the skill mix, and can we embed that in the apprenticeship scheme, and critically the new curricula being designed with the apprenticeship schools? Special issues, primary and secondary prevention in children's. Royal College of Paediatricians have done a fabulous report on why so many children, mums bring their children up to A&E and basically jam up the A&E department. It's because of the collapse of the respiratory service in the community. So therefore, there are trusts now developing community-based respiratory services for children, and we have to think and expand that, a la RC Peds report. And that changes the deployment models, particularly in paediatrics and the respiratory service, working with the school nursing service, very, very important. But it means you cut the flows into A&E of children by about 10%. So it's actually quite a good development. We have to expand massively the clinical placements, and the problem is they're in the wrong place. They need to be in primary and community care, not so much in the acute sector. And that reorientation is a lot of work. I'll come to the OD agency if we've got time in a moment. I've only got, looks like a couple more minutes. Sorry about this. I'm going to have to just whiz through this. Harmonisation of terms and conditions as we integrate across the community, very big HR agenda. For another time, perhaps, issues for GPs and general practices, the legal models complicate how we develop the staffing profile and manage change, because you've got collectives, partnerships and corporates in there. So actually we need specialists in HR who understand primary care to be able to facilitate these changes. Big stuff on skill mixes, the drugs budget, GPs, split roles, etc. For another time, haven't got time for that. Big science has arrived. This investment is ongoing right now, and it changes the art of the possible for diagnostics and therapeutics. And the genetics service, this is the genomic medicine service that has now been established. The regional centres are up and running, so that means we can start to change the diagnostics. And the pandemic has been very important in pushing that forward. Proton Beam, the two big centres are up in England. High-speed informatics, the stem cell, the changes the whole of the art of therapeutics. And we have got the 5 billion investment currently in the Crick Institute in London, which has just been given permission to recruit another 40 PhD students in this one research stream. So within 3 years, they will go to critical mass of developing the skill mix. The therapeutics of from stem cell, and that will change. We need a new kind of workforce to use stem cell therapies, particularly cancer and cardiovascular. And then prosthetics changes the whole issue of rehabilitation, which changes deployment, particularly in the therapies. Haven't got time to go through this, but just to say that there's another bundle, I think it's about 5 billion gone into this. This is the next wave of the science investment program. So these are the big laser 3D printed programs now really changing the art of the possible in surgery and in the prognosis, particularly of mobilization and limbs, hip replacements, knee replacements, etc. The personalized medicine and genomics with the predictive analytics service changes the fantastic changes to the cancer death rates and successive therapies. And similarly, personalized polypharmacy and the biosimilars. These three things change remarkably the success of cancer care. So it's more patients still in the system. Pathology, so we've had the big investments in primary community care centres, big investments in science and technology. And the third big wave is this digital pathology and imaging. So that's the diagnostics and predictive analytics service. And we've now got the 5, particularly diagnostic predictive analytics, 5 centres of excellence have been going now for a year. And they will now issue, once the reforms are through via the ICS, if they become established in law, the big centres, the protocol for running the new diagnostic and imaging, the predictive analytics service. And this changes how we organise digital and predictive analytics, the digital pathology and imaging. And very, very important, the underpinner with the data lakes and the tumour biology, all of that is supported by the National Programme on NHS Digital. So over the next 5 years, the reorganisation, restructuring of diagnostics and its expansion actually change, and its location probably in the high street. What does this do to, if you like, the efficiency gearing, particularly in surgery and gen med? So that's the sort of thing that you have to bottom out and model. Sorry, I can't do anything. I can't do the detail on that anymore. We have run out of time. And then finally, the ICSs haven't got time to do the detail. Very sorry. What we've got here is, I'm just very, very quickly, this is perhaps for another time for you. This is for the English service, although for the Welsh colleagues who are in, when I'm running a course, as you know, for Julie and Alex, starting, I think, in February. We will focus on all these issues. So we'll unpack everything in detail and what it looks like in Wales. Okay, but for the English, this is currently what the thinking is on the board structure. What you've got here are 3 sort of pillars of decision making, which are for the left-hand side is the investment boards, the development boards, clinical leadership. Then we've got the infrastructure of accountability in the middle, and then we've got the change agency. So very quickly on the left-hand side, we've got the clinical investment board. So each of these would be a strategic investment board where you locate the workforce planning, okay? And these would be headed by a chief of staff who would be probably a top clinician, and that would be for a whole ICS. The middle you're familiar with, that is the governance structure, so it's sort of the group HR, group chief exec, etc. And on the right hand side is the director of innovations, the chief of staff, which is the first 3, that's director of research, genomics and science. That is the data lakes, academic health science centres, the change agencies with respect to predictive analytics, ambulance and learning and practice development. I was going to illustrate this with an example of what this means in cardiovascular, but we've run out of time, so I'm going to just cut it there and hand back to the chairman. Thank you.
Thanks very much, Pat. I think that's an interesting presentation showing really aspects of workforce planning, a couple of aspects of workforce planning, particularly significant increase in demand and the need for systems efficiency and the potential for whole-scale change in terms of the way that the services are going to need to be delivered. And I suppose there's a knock-on impact, as you suggested, in terms of what kind of workforce. 2 elements I think I picked up in terms of, firstly, the process of assessing workforce demand and what we're going to need to be able to deal with that, and and also how are we going to encourage people to actually sort of come into this workforce? How are we going to position new roles? There was a comment in the chat function just as you were talking from Jess around about positioning organisational culture to develop or to encourage people into these new roles, which is interesting.